Hi everyone. Today we'll be talking about the diabetic skin complications, particularly Acanthosis nigricans. Now, these pictures here brought to you courtesy of DermNet, which is a great resource if you want to follow up on the various dermatological pathologies. We can see in this first picture here, this patient has a hyperpigmented, sort of thickened looking lesion on the lateral aspect of their neck. On the second picture, we can see a similar sort of presentation. Hyperpigmented region here looks fairly thickened compared to the surrounding skin, and it has fairly poorly defined edges. Acanthosis nigricans is a skin sign marked by poorly defined, dark brown to black, velvety thickening of the skin, most commonly seen in skin folds such as the neck, armpit, under the breast, and groin. You can see it in other areas like the knee and the elbow or the umbilicus, but these are the most common regions. The plaques are usually not painful, and only occasionally are they itchy or pruritic. Skin tags are common, and the lesions can sometimes become macerated. Now, as with many other dermatological conditions, the presentation varies depending on the patient's skin tone. So darker skin types may appear as more leathery and hyperpigmented plaques, and neck and facial involvement is more common in darker skin. The exact cause is not completely understood, but Acanthosis nigricans is strongly linked to insulin resistance. Conditions commonly associated include obesity, type 2 diabetes, and by extension, the metabolic syndrome. Now, how it's proposed to occur is that excess circulating insulin activates insulin and insulin-like growth factor pathways in the skin, encouraging keratinocyte and fibroblast growth and proliferation, creating the typical raised plaques of Acanthosis nigricans. Higher rates are reported among people of African, Hispanic, Native American, and South Asian ancestry. It's much less common in Caucasian patients. Acanthosis nigricans occurs worldwide and is more common in individuals with obesity and insulin resistance. This is important because the prevalence of these conditions is increasing, particularly in children. So in children, it is actually an important indicator of future metabolic and cardiovascular risk. There are other causes of Acanthosis nigricans besides insulin resistance and diabetes. So in a patient who presents with Acanthosis nigricans who screens negative for diabetes, it's important to follow up these causes. It could be drug-induced in patients who use nicotinic acid, systemic corticosteroids, or the oral contraceptive pill. It could be endocrine in nature in conditions of androgen excess like polycystic ovarian syndrome, Cushing's disease, or acromegaly. Or it could present in hypothyroidism or Addison's disease. It could be autoimmune in nature, so conditions like SLE, Sjogren's syndrome, scleroderma, Hashimoto's can cause it. And finally, it can be malignant, most often linked to gastric adenocarcinoma. The diagnosis of Acanthosis nigricans is clinical. It's based on the characteristic appearance, the hyperpigmented, velvety, thickened skin, and distribution of the lesion in the skin folds like the axilla and the neck. Biopsy is only rarely needed, but when performed shows hyperkeratosis and papillomatosis. Further evaluation focuses on identifying associated disorders and may include glucose and HbA1c testing if you want to rule out diabetes, thyroid and hormone studies like cortisol levels if you want to rule out thyroid disorders or Cushing's disease respectively, and imaging or endoscopy when gastric adenocarcinoma is suspected. Finally, the management. Treatment focuses on addressing the underlying cause rather than the skin changes alone. So improvement in weight, insulin sensitivity, or metabolic control may lead to gradual lightening and improving of the lesion. So for example, if you want to treat a drug-induced case, you may consider discontinuing the offending medicine. Or if you want to treat a cancer-associated case, the lesion may regress after tumor treatment. Medications improving insulin sensitivity, such as metformin, the PCBs like pioglitazone, or the GLP-1 receptor agonists like semaglutide or Ozempic, may indirectly improve skin changes as metabolic status improves. Now, sometimes patients for cosmetic reasons may want skin-directed treatments, and some agents that have shown some use are the topical retinoids, topical triol, and chemical exfoliants like salicylic acid.